Dr. Priyanka Chandratre from Rheumatology join us today to present on gout and chronic kidney disease. Priyanka is actually from UK. She trained in, she did her med school in Wales, did an academic fellowship from at Keele on health-related quality of life in gout. She's done her rheumatology residency in Liverpool. And she joined us, I think, in April of 2023. So we were just chatting about the fact that she's not seen a Canadian winter yet. She'll be talking to us about what seems to be a research interest on gout and CKD, of course, for us, but otherwise a research interest around crystal arthritis, including Behcets syndrome. So take it from there, Priyanka.
Thank you so much for the kind introduction, Swapnil. I'm really delighted to be here, and it's really an honor to be able to talk to you about all things gout, but I have tried to focus it towards the nephrology audience, and I'll try and keep it as relevant to you as I can. As you know, I'm Priyanka, and I'm probably one of the newest recruits in the rheumatology department at TOH. So these are some evidence-based medicine references. I'm happy to share all of this with you. I have no conflicts of interest or disclosures relevant to this presentation. I wanted to talk to you about gout and really kind of its love for comorbidities in particular, and focusing on chronic kidney disease to see whether there is a bidirectional relationship or which is chasing which. I wanted to discuss the current practice in the management of gout and CKD, but also look at what, if anything, is new and in the pipeline, and then finally discuss some clinical unmet needs as well as research priorities. So we know that gout is caused by hyperuricemia. That's the mainstay of MSU crystal deposition. Once the uric acid level goes beyond 6.8 milligrams per deciliter, which is roughly 350 micromoles per liter, MSU crystals start to deposit in and around the joints. And we know that studies of Mendelian randomization show that actually the higher the uric acid, the greater the likelihood of developing gout. So we also think that hyperuricemia is the cause of many underlying comorbid conditions. You can see here that CKD in particular, let me see if my pointer will work. So CKD in particular has a high prevalence in men, but actually probably even higher in women. And we know that women tend to get gout at a more delayed or advanced stage and have polyarticular presentation with worse CKD from clinical practice too. So, the relationship between gout and CKD is a complex one, but a very important one. We know that actually there are multiple implications, such as people with chronic kidney disease may not be able to have quite appropriately non-steroidal anti-inflammatories for the acute phase of gout. The colchicine use is often restricted and done with caution, although you may be much braver than me in using colchicine. The chronic treatment of gout is also then suboptimal because many uricosurics, such as particularly lesinurad, has now been withdrawn from the market because it showed higher progression of CKD, particularly 3 and over, in combination with a xanthine oxidase inhibitor. We know that people are scared and apprehensive of using urate-lowering treatment in general in CKD with slow titration, if any titration at all. And all of this then leads to suboptimal management of gout. And converse is also true. There is a high prevalence of gout in people, or hyperuricemia, I should say, in people with CKD. But other comorbidities are also highly prevalent and shared among the two conditions. For example, hypertension, type 2 diabetes, peripheral vascular disease, and cardiovascular disease. So this is a study from the Korean National Health and Nutrition Survey, which shows that actually the prevalence of CKD overall is about 2%, and that tends to be the ballpark figure in the UK as well from the primary care database. In Canada, in a study in BC, the prevalence is about 3.8%, but actually in the US, it's much higher at 9%, particularly in adults over 60. And we know that the prevalence is rising, particularly in the Western Hemisphere. We can see here that actually chronic kidney disease, that the odds ratio, the risk of developing chronic kidney disease and gout is 4-fold in males and higher, 11-fold after adjusted for comorbid conditions and lifestyle choices and socio-demographic characteristics, it's even higher in women. So really, the key message that we would like to get out there is that gout comes with a lot of comorbid conditions which need to be addressed early in order to prevent adverse outcome, both in gout and its associated comorbidities. So I'm almost embarrassed showing you this slide, and I'm sure you know this way better than I do, but this is my understanding of the renal transport of uric acid. So the uric acid is presented to the glomerulus for filtration. It is then reabsorbed at the S1 segment of the proximal convoluted tubule, but it's mainly the fractional excretion is low, so the main method of the transport is reabsorption, which happens at the apical and the basolateral membranes via many organic anion transporters, particularly at the apical membrane and at the basolateral membrane by glucose, high-affinity glucose transporters. Once in the interstitium, it's then circulated back into the renal tubular cell by different organic anion transporters, and from the intercellular compartment into the lumen again by multi-drug resistance protein and ATP binding cassette groups. So the uricosuric drugs act at the organic anion transporters to promote the excretion of uric acid, and diuretics act at these transporters to increase hyperuricemia or reabsorption of uric acid. So the relationship between gout or hyperuricemia and CKD is multifactorial. There are animal studies which show that actually even in the absence of crystals, hyperuricemia can cause progression of CKD. So one theory is that hyperuricemia may cause oxidative stress, endothelial dysfunction, both systemic and glomerular hypertension, leading to arteriosclerosis and interstitial disease. However, it's not that simple. I think in CKD, there are also other comorbid conditions, for example, hypertension due to salt and water retention, peripheral vascular disease, diabetes. So it's not always easy to predict whether hyperuricemia in CKD will cause disease progression, or is it the other confounding comorbid conditions. However, some studies have shown that actually hyperuricemia in CKD in the presence of IgA nephropathy and type 2 diabetes does lead to disease progression, particularly in people with normal uricemia. Normal renal function. Hyperuricemia will lead to kidney disease eventually. So, you know, it's really a kind of, we think it's a bidirectional relationship, but it's difficult to tell which happens first in many cases. So this is a study from the UK, actually. We know that hyperuricemia is associated with chronic kidney disease, but we don't know much about the level of hyperuricemia and the stages of chronic kidney disease. So this is a study nested within the primary care database, which shows that actually the higher the serum uric acid levels, so it's divided into quartiles, and the higher the quartile, the greater the chances of getting CKD stage 3 or higher, and the rate is also fastest in the highest uric acid quartile. This is also associated with higher all-cause mortality. And as you can see here, most people in this study did get urate-lowering treatment with Alopurinol or Febuxostat, yet the uric acid generally tends to be above 6, indicating suboptimal disease control, which, you know, actually, had it been addressed properly or had the dose been titrated, it would incur many benefits to people with gout and chronic kidney disease. This is taken straight from the American College of Rheumatology, and these are indications for urate-lowering treatment. So you can see that actually ACR and other international guidelines will advocate the use of urate-lowering treatment in people with 2 or more flares, radiographic evidence of erosive changes, tophaceous gout, or urolithiasis. But you can see here that actually patients with even 1 flare and CKD stage 3 or higher could conditionally be prescribed urate-lowering treatment, so that the bar is lowered, if you like, in the presence of CKD3 or higher. And yet, despite these, you know, national and international guidelines, the management of gout is suboptimal generally. There are many factors for that, which I'll touch upon, but I think it's even worse in the context of CKD. And I think even rheumatologists find it very challenging to manage gout and CKD. Hence, which is why I've approached you guys to help with possibly a combined clinic in the future, but we can chat about that later. So we know that the adherence to guidelines are difficult because guidelines are variable. For example, ACR will recommend a different target uric acid level compared to BSR. We know that only a minority, about 15% of those with an acute onset of gout, are referred to rheumatology for further management. And there's a general lack of awareness around the implications of gout and its more systemic effects. Finally, it is still associated with stigma, for example, adverse lifestyle choices of excess alcohol intake or indulgence in unhealthy dietary habits, and people may not be so forthcoming to seek medical advice or attention. But I think, there's more than just a physician and a patient level problem here. I think there is a systemic problem. We know that clinical trials often exclude people with CKD3, particularly advanced CKD, and therefore we don't know the outcomes in that category or stratification of people. We know that the outcomes are presented in a very variable manner when it comes to the outcomes for gout particularly, but also there's no stratification according to the kidney function. So all of this then leads to a great deal of confusion, and people harbor fears about trying to use urate-lowering treatment. They often fear it may worsen kidney function, or that urate-lowering treatment may not be as efficacious in CKD. And quite rightly, they are concerned about adverse events. We know that hyperuricemia treatment in gout in context of CKD is not always benign. There is a risk of Stevens-Johnson syndrome. I guess checking the HLA-B68 would be helpful in identifying people who are at risk of this outcome, but it's not routine clinical practice yet. So, there is still a lot of concern about the treatment of gout and CKD with urate-lowering therapies. So where are we now? So this is a study from one year study of electronic health records based in primary care, which identified people with gout and CKD stages 3 to 5 using the ICD-10 codes, and 121 records were manually trawled to look for, to confirm rather, the diagnosis of gout. And the ACR 2020 criteria was used as a benchmark for guidelines for the standard of treatment for gout. And you can see that the majority had CKD3 here, followed by stages 4 and 5. The average GFR was just in the 30, and only 16% had optimal management, which is really, well below standard, as defined by the 2020 ACR guideline criteria. And the reasons were multifactorial. Mostly it's because uric acid is not measured at regular enough intervals. The urate-lowering treatment may not be titrated up as it should. It may not be started at all. And often there's more than one reason. So, there's still a lot more work to do. And with that, I'll just give you an example of why things are difficult. So this is a patient who I've seen in clinic, renal transplant done 20 plus years ago, hypertensive 68-year-old lady having recurrent gout attacks affecting the usual distributions of first MTP joints causing podagra, bilateral knee swelling and synovitis, and hand synovitis too, with tophi evident on clinical examination, uric acid well above the target of 350 micromoles per liter, GFR low and creatinine high. And she's currently on azathioprine, which poses a problem for urate-lowering treatment due to its interaction with urate-lowering treatment and risk of myelosuppression, an increase of azathioprine metabolites, therefore causing leukopenia and azathioprine toxicity. She's also on tacrolimus, which may increase hyperuricemia, and furosemide, which then again increases the risk of hyperuricemia and frequent gout attacks. Thankfully, she is on losartan, which is a mild uricosuric drug, and so is ezetimibe. But what would you do here? What would you give her? Well, I'll tell you what I did. I asked the nephrologist to swap the azathioprine to mycophenolate, and then I gave her Alopurinol. But this is just to illustrate the teamwork needed and the complexity, really. And particularly, I find kidney transplant tricky because of these reasons. So, these patients are often hypertensive. They're on a diuretic, which then, as I said, increases risk of gout. They are on medications which have potential for interaction. For example, cyclosporine may interact with colchicine, and there's risk of neuro and myotoxicity. There are drugs, like we mentioned earlier, like tacrolimus and cyclosporine, which increase uric acid levels through renal absorption. There are also potentials for interaction between urate-lowering treatment and immunosuppressive drugs. So it's often, very complex, and we need your help in managing this. So this is a study which, shows the risk of gout post-transplant, post-renal transplant. This is we know that gout is associated with high rates of morbidity and mortality in renal transplant, particularly with more severe bone erosions and cardiovascular and worsening renal disease after transplantation. The incidence of gout post-transplant used to be as high as 13%, but now actually is much lower because cyclosporine, which was the mainstay of treatment, from my understanding previously, is now no longer being used so frequently. This is a large population study which shows that actually at any point, 25% of people had gout, either before or after transplant. Majority were males, Afro-Caribbean, and majority were on tacrolimus or mycophenolate. But the risk of gout, incident gout post-transplant, was about 5%, which is roughly compatible with the general population. And that may be because of reduced use of cyclosporine. But nevertheless, the risk factors for developing gout post-transplant included the metabolic syndrome features of hypertension, dyslipidemia, obesity, plus higher baseline uric acid, type 2 diabetes, and use of diuretics. So how should we manage gout in chronic kidney disease? So I think we should still adopt a treat-to-target approach. This is recommended by national and international guidelines such as ACR, which advise that the target uric acid level should be 6 milligrams per deciliter in the absence of tophi and 5 in the presence of tophi. We know that we may need to use treat-to-target approach up to 2 years in order to reduce gout flare frequency compared to standard care. And this is a post hoc analysis of a randomized controlled trial between Febuxostat and Alopurinol, where participants were randomized 1-to-1 to each drug. And you can see baseline uric acid was above 6.8 milligrams per deciliter. The first phase was all about titration of the urate-lowering treatment up to week 24, and then between weeks 25 and 48, maintenance, but escalation if needed to hit that target uric acid or until the maximum dose of the urate-lowering treatment was achieved. And then the third phase, looking at the primary outcome of more than one flare. And there was no significant difference between baseline characteristics of participants in the flare-free group and more than one flare group. But interestingly, participants who had hit the target of less than 6 milligrams per deciliter were 60% less likely to have a flare at 18 months. So, it's really worth thinking that treat-to-target could have benefits in reducing the flare frequency as early as 12 to 18 months. So I would support the treat-to-target approach here as recommended by ACR. In addition to lowering the frequency of flares, it also has renoprotective effects. So this is a study which is a randomized multi-center observational study for 4 years, and this identified patients with gout according to the ACR criteria and CKD stage 3 treated with any urate-lowering treatment, either Alopurinol or Febuxostat, followed at 6 months and at 12 months. Interestingly, again, kidney transplant and single kidney patients were excluded. Mean baseline uric acid was very high, above 8, and GFR 45. But you can see here that actually at 6 months, the GFR has increased, and same at 12 months. And this is inversely proportional to the level of uric acid at 6 and 12 months. So, apart from having reduction in flares, we're also seeing benefits in CKD parameters. And non-smokers and males were more likely to have a reduced progression of CKD. We know women tend to have more aggressive disease, both in gout and CKD, so that kind of fits with our general clinical experience as well. But this is the data I've shown you is in gout, and in asymptomatic hyperuricemia, this is not always the case. So we don't advocate treatment of asymptomatic hyperuricemia in the context of CKD. So if they don't have gout, I wouldn't tend to advise allopurinol, based on 2 studies, randomized control studies, which show that actually compared to placebo, there's no effect of allopurinol lowering or reducing progression of CKD. However, these 2 trials were slightly flawed in that one recruited patients just with type 1 diabetes, and the other had to end recruitment because of basically they failed to recruit the numbers they desired. So perhaps not powered to look at the primary outcome. And this is a seminal paper by Lisa Stamp, and this really is what I follow in clinic, and this is to kind of give me a rough conceptual framework to start uric acid lowering treatment with allopurinol. This is really based on GFR, and this is a retrospective case control trial looking at patients with gout who developed allopurinol hypersensitivity syndrome. The 3 cases were matched, one case was matched to 3 controls, and they were matched for gender, diuretic use, GFR, and they were followed for development of allopurinol hypersensitivity syndrome. We knew that people, there was 54 cases of AHS, and people who had the highest allopurinol starting dose were at 23% greater risk of developing AHS compared to people who had the lowest quintile of allopurinol starting dose. So the recommendation was to start allopurinol 1.5 milligrams per unit of GFR, essentially. And this is roughly what I follow in clinic, with cautious monitoring of their renal function probably every 4 to 6 weeks. So once we start allopurinol, how do we escalate it? That's the next question. And this is a paper which is now outdated and widely disregarded, actually, but I've just put this to obviously to generate some discussion and get your views as well. So this is a paper which recommends that the allopurinol dose should be maintained according to creatinine clearance. But we know that, and this is because the risk factors are for allopurinol hypersensitivity syndrome are age, female gender, diuretic use, as well as the HLA-B5801 genotype, which is more prevalent in the Han Chinese, Thai, and Vietnamese ethnicities. But there is still confusion. So, for example, EULAR recommends sticking to this regime of allopurinol titration based on creatinine clearance, whereas ACR will recommend titrating the dose beyond that recommended by the creatinine clearance. And I think in practice, that's what we tend to do, as I say, with very cautious monitoring of the renal function. With that, we'll move to the next patient that I've seen. So this is a 52-year-old lady with familial hypercholesterolemia, lots of calculi everywhere, salivary, renal, having gout attack, mainly actually only once a year. But she's already tried allopurinol and had adverse cutaneous drug reaction and rash to that. She's currently on the mild uricosurics, fenofibrate and losartan, but uric acid is again above target level. GFR is reasonable. She has got some fatty liver disease. Ultrasound confirms presence of tophi. So what would you do? She's having one attack, but she's got tophi. She's got renal calculi. So I did treat her. I actually, what would you give her? Would you recommend allopurinol desensitization, or going for Febuxostat, or uricosuric, such as probenecid or benzbromarone? Feel free to shout out if you want. So, okay. Febuxostat, yeah, excellent. So that's what I did. I did give her Febuxostat. And, you know, there's some comfort now in knowing that actually Febuxostat is metabolized largely by the liver, so we're not so concerned about impaired renal function in Febuxostat. There is still a scarcity of data about use of Febuxostat in chronic kidney disease, but generally speaking, there is no need for dose adjustment, and it's safe to use above GFR, safe to use in GFR above 15. It doesn't, as far as I know, have any cross-reactivity with Alopurinol, so the risk of severe cutaneous adverse reactions are low. And, you know, as per FDA, the dose should really be restricted to 40 milligrams if the creatinine clearance is between 50 and 30. But as I say, there's very little data in renal transplant patients, in advanced CKD, and in hemodialysis. So, you know, we don't know exactly how to titrate for these patients. There was a lot of controversy about Febuxostat, actually, mainly from the FDA-mandated CARES trial, which showed that there was an increase in cardiovascular and all-cause mortality in the Febuxostat group compared to the Alopurinol group. This study, however, was really marked by multiple, you know, flaws, I think, including high dropout rate, events of cardiovascular morbidity and mortality happening after drug discontinuation, and a large number of patients were lost to follow-up. So the better trial, I think, is the FAST trial, which is the EMA-mandated more recent trial, which doesn't have any concerns in terms of cardiovascular morbidity and mortality, although the population was mainly white males and they were also elderly. I think currently the ACR, taking into account the CARES data and the FDA black box warning, has advised to swap people on Febuxostat on to an alternative if they've got severe cardiovascular disease. But we're hoping that by the time the guidelines are reviewed, the next review, this restriction may be lifted in light of the new data. So this systematic review really looks at all the studies of Febuxostat and cardiovascular safety, and apart from CARES, there are no real signals here. So again, we're comforted in using it in patients with cardiovascular disease. So this is a study looking at the rate of flare of gout attacks between Febuxostat and Alopurinol. So this is a post-hoc analysis from the Stop Gout trial, which basically looks at the first 24 weeks, and the predictors of flare were adjusted for comorbid conditions, sociodemographic characteristics, renal function, and lifestyle choices. And you can see that actually there's no significant difference between Alopurinol and the Febuxostat group in terms of time to first flare, and there was no significant difference between the baseline characteristics of participants allocated to Alopurinol or Febuxostat group. So this study really indicates that the risk factors for flare are not necessarily which type of urate-lowering treatment is given with colchicine, but it's younger age at disease onset, higher uric acid level at baseline, and interestingly, absence of tophi. So this is another case. This is a 56-year-old man with hypertension, diabetes, gout, previous excess alcohol intake, currently on Febuxostat maximum dose, also on losartan, treated with prednisone for acute episodes. He's already had the maximum dose of Alopurinol as well, but despite these two interventions, his uric acid is consistently above 500. So he's getting frequent attacks every 2 to 3 weeks, and he's got obvious tophi, you know, on his feet. And what would you do in this case? He's already had Febuxostat, he's already had Alopurinol, maximum doses. Where do we go from here? Any takers?
Send them to you.
Excellent, thank you. That would be very helpful in establishing a combined clinic. Thank you, Swapnil. Yes, do send him to me. But so what I did was I used uricosuric here. I gave him probenecid, which is difficult to get hold of actually in the UK particularly, and I'm sure it is here as well. So uricosuric drugs are used as long as renal function is, broadly speaking, the GFR is above 30, but we know benzbromarone can retain its efficacy even at GFR of 20. However, there are concerns about hepatotoxicity, so it's really restricted to a named patient basis. Lesinurad actually has been withdrawn from the market now because of progression of CKD in combination with a xanthine oxidase inhibitor, so it's no longer being marketed. So we are slightly restricted in uricosuric use, and we don't really know what happens when they have severe renal disease or if they are on renal replacement therapy. So if we're really struggling and we can't use uricosurics, the other option may be pegloticase. So in most mammals, except for humans and higher primates, there is an enzyme called uricase which converts uric acid into allantoin, and then that is more easily soluble and degradable. But humans lack that enzyme, so pegloticase is a humanized uricase, which is highly immunogenic, actually. So there are concerns about its use. It can lead to infusion reactions and anaphylaxis, and a rise of uric acid level between infusions above 6 milligrams per deciliter can signal a risk for infusion reactions or anaphylaxis. So it has to be used with caution. But this study is the mirror study looking at, it's a randomized control trial of pegloticase given 8 milligrams biweekly in combination with methotrexate standard dose of 15 mg per week or with placebo. And the baseline uric acid criteria was over 7. They had to have failed urate lowering treatment or have intolerance to it, have frequent flares or tophi, and people with G6PD were excluded due to risk of hemolysis. We would also not use this in severe congestive cardiac failure. And again, people with severe CKD were excluded, sadly. So it did show, however, that 60% of people on methotrexate and only half of that met the primary endpoint of target uric acid level of 6 or lower. 63% in placebo, but only 23% had to discontinue the drug because of the high uric acid level between infusions, which would put them at high risk of infusion reactions. And interestingly, people with tophi at baseline, so a huge proportion, over half, had a complete resolution at 52 weeks, compared to only about a third in the placebo group. And the safety profile was pretty similar between placebo and methotrexate groups, so no concerns using methotrexate in combination. And often we would use pegloticase with methotrexate or mycophenolate to prevent the immunogenic side effects. So which are the big players in the market right now? As you can see, it's basically allopurinol. It's 85%, of all ULTs prescribed are allopurinol. There's a little bit of febuxostat, probenecid, and tiny slice of pegloticase, but really we're dependent on allopurinol still after so many years of having a good understanding of the pathophysiology of gout. This is my take on use of colchicine in acute gout or flare prophylaxis, and you may not agree with this at all, which is why I've put it here. So, and I've had discussions with your team members about this already. So I tend to avoid colchicine if GFR is less than 10 and use it at half dose of 0.3 if GFR is less than 30. But I was told that we can use it in hemodialysis patients. So, I'll be looking forward to having a chat with you about this as well. This is a study looking at the advantages of colchicine in CKD progression. This is a study from Korea. It's a multi-center nested case controls study of 3 Korean hospitals, and patients with CKD 3 or 4 were recruited for this study. They were given allopurinol or febuxostat, And the primary endpoint was CKD progression, which was defined as greater than 40% decrease from baseline of the GFR or the onset of renal failure needing replacement treatment. And controls were matched to cases based on follow-up time, age, and gender. So you can see that actually people with 90 or more cumulative dose days of colchicine had lower odds ratio of progression of CKD. And this was, as I say, adjusted for type of ULT, sociodemographic characteristics, renal function, and diuretic use. And the effects were even more pronounced in people with diabetes or hypertension. So colchicine, having shown you the previous slide, looks like could be useful in CKD after all. So again, what do we use for acute gout with CKD and congestive cardiac failure? So quite rightly, I would not use NSAIDs in both groups of patients. Colchicine, as I said, I use modified doses in CKD. Interestingly, actually, colchicine has been approved by FDA as for prevention of cardiovascular disease, so I have no concerns using it there. But then there are concerns about interaction with statins, which most patients are on, which is a project that we're trying to look at with Manish. So I do use steroids in both groups, although with congestive cardiac failure it may not be ideal in terms of fluid retention, but short courses can be used. And then the new thing that we are going towards is canakinumab, which compared to a steroid reduces the risk of renal progression and new flares, and has also shown some cardiovascular safety compared to steroid. So this is really looking at so we talked about the renal benefits of colchicine. This is looking at the cardiovascular benefits of colchicine. So this is data from electronic health records linked with Medicare claims. And these patients were all diagnosed with gout. The new users of colchicine were identified at baseline and then followed over a period of time. And non-users had never had colchicine prescription, and they were matched for follow-up, age and gender. And the composite primary outcome was MI, non-fatal MI, non-fatal stroke, and TIAA, and then all-cause mortality. And you can see that actually after full adjustment, colchicine was associated with a 49% lower risk in the primary cardiovascular composite outcomes and a 73% lower risk in all-cause mortality. So again, favoring the use of colchicine in cardiovascular disease. And this is a CANTOS trial, which is looking at the safety of canakinumab compared to placebo. And this, the primary endpoint was myocardial infarction, non-fatal stroke, or cardiovascular death. And the secondary endpoint was admission to hospital for any of these conditions. And canakinumab, 150 milligrams compared to placebo administered every 3 months, was superior and had lower rates of both primary and secondary outcomes. It's also shown to reduce pain intensity and also time to gout flare. So this is safety and efficacy data based on canakinumab versus triamcinolone administered at baseline then as patients had gout flares, and primary endpoint being pain intensity at 72 hours and then time to next gout flare. And you can see that canakinumab has a lower level of pain as determined by the patient visual analog score and lower rates or time to flare for the next gout episode. So all of this meant, of course, that FDA has approved canakinumab for treatment of acute gout flares. And it's, as we see, that it's also okay to use in CKD, although we don't know about severe CKD or transplant patients. So the next thing I want to touch on briefly, mindful of time, is the SGLT2 inhibitors, which have numerous, you obviously prescribe this much more than I do. It has numerous cardiometabolic and renal benefits. And so, we know that it can lower uric acid, through prevention of reabsorption at the renal tubular cell, but does that translate into clinical benefits with reduction in inflammation and reduction in flares? So this is a data which looks at SGLT2 compared to DPP4, which is a second-line glucose-lowering agent. And these patients were all propensity score matched. And it looks at the outcomes being recurrent gout flares as defined by the primary care database, but also admission to hospital or ED with gout flares. And for both, you can see that SGLT2 led to much lower rates of gout flares, both in the community and in patient admissions. So really, there may be a role for SGLT2 in the use of, in the treatment of gout in patients with type 2 diabetes, just irrespective of which urate-lowering treatment they are on, be it Febuxostat or Alopurinol. And this is, again, a study which looks at SGLT2 or sulfonylurea, which is more of a standard treatment for diabetes until now. And it looked at uric acid target level of 6. All patients had gout, classified by the ACR-EULAR criteria. And then it looked at the baseline, the change from baseline to follow-up period. And you can see here that SGLT2 leads to a greater reduction in uric acid levels compared to SFU. And all of this was adjusted for sociodemographic characteristics and the type of urate-lowering treatment used as well. So this may be the much needed drug that we are waiting for treatment of gout, but so far all studies are only on patients with diabetes, so we don't know about patients who don't have diabetes and have CKD and gout. So apart from SGLT2, what else is new? So this is hot off the press. This is from ACR just this month. And this is a phase 2b double-blinded randomized controlled trial of this uricosuric drug, which is being conducted across Southeast Asia and Australia and US. Participants, again, GFR is greater than 30, and they're randomized 1:1:1 with placebo, a lower 50 milligram dose or 75 milligram dose of this drug. The baseline uric acid is quite high at 8 and was similar across the regions, but as expected, there was variation in comorbid conditions. For example, higher comorbidities in people of Taiwanese ethnicity who tend to have more prevalent, more prevalence of gout and more metabolic syndrome disorders. And we're still waiting for full results, but you can see that actually the mean uric acid level was lower with both the 50 and 75 milligram doses, with sustained response at week 12 in both the per protocol and intention to treat populations. The main side effect was gout flare in about a third, but this is also seen in the placebo group. So, you know, it's looking hopeful. We'll see how this pans out in the future. And then these are the other drugs that are in the pipeline, and these really kind of target the renal urate excretion, minimizing immunogenicity of uricase-based treatments, and additional targets of purine metabolic pathway, leveraging the GI excretion of uric acid, and finally addressing the targets of interleukin-1 and inflammasomes, which we know are hugely implicated in acute gout flares. So hopefully some of these are already in phase 3, and we may have some exciting new drugs soon, fingers crossed. So with that, I'll just move on to research priorities. So we don't know much about what happens in terms of natural history of gout and CKD. We don't know who to pick for aggressive urate-lowering treatment. As I said, we don't have data on patients with severe CKD from clinical trials, and the reporting of outcomes is hugely variable. So some of these questions are, how do we use colchicine in dialysis patients or transplant patients? What is the risk of drug interactions, particularly with, colchicine and statins and cyclosporin? Do we use NSAIDs at all in CKD? And what about, apart from canakinumab, what about other IL-1 inhibition in CKD? Particularly, how quickly can we escalate the treatment? We know now, a bit about the risk factors for allopurinol hypersensitivity syndrome, but what happens to that risk as we titrate the dose up? And does dialysis improve the outcome in AHS? Can we predict the dose of allopurinol, the target dose stratified by GFR? Febuxostat is so far safer than allopurinol and CKD, but the trials were restricted in that they only used allopurinol up to 300 milligrams, so it's not been titrated to full dose. So these are some of the kind of key questions that the people who have interest in crystal arthritis have identified. This is kind of our attempt to address some of these questions. This is a study which I thought was interesting, which we have applied for funding, and this is to look at the prevalence of MSU crystal deposition in patients with psoriatic arthritis, but not diagnosed with gout yet, and to look at how uric acid levels associate with MSU crystal deposition, and to determine whether disease severity, subjective and objective, so tender joints as reported by patients, or positive power Doppler or X-ray changes of erosive gout, how do these associate with crystal deposition? And finally, a study which we're hoping will take off with help of Manish here, looking at ICES patients over 65, comparing the risk of myotoxicity in people with gout who are given statin in combination with colchicine compared to other anti-inflammatory drugs for treatment of acute gout. And we would look at the composite outcomes of myotoxicity, as I put there, CK, liver enzymes, myoglobin, renal function. And if possible, we would like to limit this to those do a secondary analysis limited to patients with GFR less than 60, look at the cumulative dose response to colchicine, and also if sufficient numbers, look at each statin by group. So I think that's pretty much it from me, because I've left a little bit of time for discussion. I hope that's okay. Very happy to take questions, and thank you so much for your attention.
Thank you. That was a wonderful overview. So the floor is open for questions. I'm sure there'll be discussion on the colchicine aspect. There is someone, I'll get to the question in the chat, but from the conference room first.
And show so I can see you. Yeah, okay.
Hi, thank you, Priyanka. This is David, one of the nephrologists. Regarding when you mentioned the difficulties in instituting urate-lowering therapy, I thought it was very interesting. And one thing that I often think of is that when you're starting it, you're actually starting two drugs because you start the colchicine prophylaxis. And I find it kind of harder to sell to a patient. And when I think about it, you have to explain to them that the drug that actually helps can actually make things worse at the beginning, and so you need to give them something else. Do we know what the evidence is for that? Like how strong of a recommendation is that colchicine prophylaxis when you're starting it? And is there clear evidence to show that it's beneficial?
Yeah, so I think, prophylaxis with colchicine or other anti-inflammatory, but in CKD, obviously, it's restricted to largely colchicine or short courses of steroid. It's beneficial because there is a risk of gout flare post-ULT initiation due to crystal shedding, which is a sign of successful treatment. So I try and explain to the patient that actually, when you get a gout flare, when you start urate-lowering treatment, and it's usually within the first few weeks, that means that the treatment is working. And to combat that acute flare, we will give you a prophylactic. And you can now present to them data which shows the effect of colchicine, which reduces the progression of CKD. So I think, it's reasonable to use it. Again, whether, we use a modified dose of colchicine in patients with severe CKD, but that's what I do. If there are risk of interactions, for example, if they're on cyclosporin and a statin, I may avoid colchicine and may go for short course steroid completely. So yeah, it's kind of case by case, but I do try and explain to them that it's beneficial in the long term and to persevere with the treatment.
And thank you.
Sorry.
Oh, David wants another question.
Yeah, no, just to follow up. So because, we do have transplant patients, they're almost all on statins and some of them are on cyclosporin. So would you, would you be increasing the prednisone dose a little bit, to avoid colchicine in that case?
Yeah, so if they're already on prednisone, that's actually easier because I just increase their dose for the first 2 or 3 weeks to, if they're on 5 milligrams, I make it 10 milligrams for 2 weeks and then drop that back down to 5. So then I avoid adding another drug like colchicine to minimize polypharmacy and risk of interaction. Absolutely.
Thank you.
Thank you. Dr. Knoll.
Just going to shut my camera off. It's looking a little shaky, my connection. Thanks, Priyanka. Just wondering if you could just review this again. You showed the starting doses of Alopurinol in CKD, but I wasn't quite sure what maximal dose you would go to in patients with CKD, because you had showed a slide that you didn't agree with, but I wasn't sure what your practice was.
So I will just put that up again if I can. Hang on. Sorry, I've kind of lost Teams now. Sorry, one sec.
I mean, you don't have to show the slide, but like, what would you, in someone say GFR is less than 30, what kind of, if you're treating to target, what kind of allopurinol dose will you finally just say, okay, that's enough, I'm not going any higher?
Okay, so yeah, so I tend to escalate beyond 300, to be honest, monitoring their renal function. So it really depends on, and then there is this discussion with the patient about treat to target. So you do explain that actually the target level is 350 micromoles per liter. You're still over that. You're now on 300 milligrams of allopurinol. And I usually increment in half doses if they've got severe CKD, and I monitor their renal function and uric acid every 4 weeks. So I would go beyond the recommended table that I showed you. I'll try and put that up again in a second. So yeah, and the starting dose I do stick with, so 50 milligrams bi-weekly if they're on, end-stage renal disease, or 50 milligrams alternate days for patients with CKD 4 or 5. So I do stick with that. So I do go in half increments, but then once they're established, I'm happy to go above 300. And most of these patients are monitored heavily, both by us and you. So I think that's reasonable. I counsel them fully about risk of allopurinol hypersensitivity syndrome. They have my number. They have been advised to stop the drug as soon as they notice a rash. And so, they're fully counseled for that.
And the HLA-B58 genotype is, can we get that readily here? And
we can. So it's on EPIC. If you go to, I think it's genetic studies, there is and I can circulate this because I have it on my email because I request this a few times a month. So you can, and it's very easy. It's literally through EPIC. You just pick genetic studies, and then there's a subcategory of B5801.
Okay.
And the turnaround time is good. It's a week or 2.
But I was just wondering your practice around that, just because we don't want to presume someone's ethnic background. So do you order it routinely? Are you very selective? Like, how do you actually order that?
I do order it in people of Southeast Asian ethnicity, particularly Vietnamese or Thai or Chinese ethnicity. So yeah, and especially if they've got CKD, I do request it before initiating allopurinol.
Okay, thanks.
Yeah, sure.
Before I jump into Peter's question, can I ask one? Is that how often do you see AHS if someone is actually B58 negative?
I have, yeah. So I don't know the figure, but I have seen it in patients who they didn't have the HLA-B5801 tested, but I've seen about, in my 6 years of being a consultant or staff, I've seen about 3 or 4 cases of AHS. So not quite 1 per year, but yeah, I have seen few.
Okay.
And many of them, the rash doesn't fully subside. So it's then difficult to actually initiate Febuxostat. Although I do, but I just tell them that if it worsens, then stop. But some of them still have the remnant, rash or sequelae of it.
Okay, let's go to Peter, who has probably told all of us that you can use allopurinol and colchicine in severe CKD.
Yeah, but I have a different questions about uricus urix, which I hardly ever see. And I had thought in the past people said they increase uric acid stones. Is that true?
Yeah,
And
so you would avoid that in people with renal calculi, and so I don't use it in people who've got a history of renal calculi, and I do ask the patients to maintain adequate fluid intake, even when they don't have renal calculi, of 2 liters per day at least.
And I just looked, and probenicid's not on ODB. So, and really, I've seen about 2 people on it in the
Yeah.
last 15 years. And I thought it must be somebody really old-fashioned prescribing it, but should we use them more?
I mean, it's certainly a drug that I have used for a few patients back in the UK. I've had fairly good response with it in some patients. It's not as good as xanthine oxidase inhibitors, I have to be honest, from my clinical experience. And you do need to titrate the dose up to the maximum. But when you're really stuck and you can't give them Febuxostat if they've had unstable angina, if they've had, massively deranged liver function.
Do you use them as add-on? For instance, I have
Yeah.
a guy with terrible tophi, a creatinine of 250, GFR about 28. His urate is still 450 on 600 milligrams of Alopurinol. What should I do?
So in that guy, I would swap him to Febuxostat as long as he's got no severe hepatic, enzyme derangement. And I think I would try Febuxostat, and if that doesn't work, I would combine either Febuxostat or Alopurinol with the probenecid or sulfentrazone. I have used it in combination with xanthine oxidase inhibitors for refractory gout cases.
And of course, I'll throw in my last, the 2 pharmacokinetic studies on colchicine shows that there is 0 accumulation even in end-stage kidney disease. And all those things with red warnings and flags are based on anecdote, not on pharmacokinetics. So I think they're dumb. And it's yet again renalism. I recently saw a almost on dialysis patient with bad pericarditis who was denied colchicine until I met him about a month later, and he got colchicine. His pericarditis got better. So
is it
renalism?
Okay, so my understanding was that it's not filtered by hemodialysis, but is it?
Yeah. So no, because it's cleared by the liver, so the kidneys or the dialysis don't matter at all. We should use the same. Sure, old frail people start with the lower dose. We should use colchicine in people with kidney disease. And I can send you the 2 references of the 2 pharmacokinetic studies.
I think it's more concerned about the half-life being higher in end-stage renal disease. No.
But it's not.
Okay.
So Peter, along those lines, you would still use it once a day, and like in typical gout flares where you're said, hey, keep using it every 2 hours or every 4 hours until the flare goes away. You wouldn't do that, right?
No, nobody does that anymore anyway. Well, were you trained in 1980? Come on.
So just once a day, and I remember you saying, I'll come to Todd's question, but I remember you saying that if there is accumulation, there's diarrhea, and there is some GI clearance of colchicine. Is that still accurate?
I did not say that. I don't know anything about whether the diarrhea is idiosyncratic, or it seems to me it's quite variable. I doubt it has to do with accumulation. I doubt it clears the drug. If you got bad diarrhea, take less.
Okay.
But Priyanka might have another view.
And I think that answers Tamara's question in the chat as well. She was asking about, how would you suggest dosing? And she has used 0.6 milligram in ×1. And I guess that's then not giving too much, right? 0.6 milligram daily is acceptable in advanced CKD and should be something we should embrace in dialysis. So I'll come to Todd's question and then Ayub. And if you're okay, Priyanka staying on beyond night to answer questions and discuss.
Sure.
Yeah, I guess it's kind of like dosing the NSAIDs until the ears ring, right? You give enough colchicine until they get diarrhea and then you back off a bit. That was an amazing overview. Thank you. I learned a lot. I wanted to come back to that question about prophylaxis. Most of my patients have been just fine on colchicine. I use it a lot. I see quite varying recommendations. You know, some people say, oh, you need a month of colchicine before you start allopurinol, and then you need to continue it an additional, 6 months, for example. The way you were speaking is it's just a few weeks. What are your thoughts in terms of length of prophylaxis? And then my other comment was, to Peter's comment, this idea of renalism, I don't know how many times we get letters from family doctors. They are very, very afraid of using these medications in early to moderate CKD. And so I appreciate your education, and to kind of disseminate that education more broadly would be greatly appreciated as well. So.
Yeah, no, thank you, Todd. So the guidelines are really variable about prophylactic length, particularly. So, people go from few days to the whole 6 months. So usually it's, again, patient dependent as well in many respects, but I'm happy to use it for, I say few weeks as a kind of rough ballpark figure. But again, if they're having recurrent gout attacks, they've got a high burden of disease, I'm having to titrate the allopurinol quite frequently, every 4 to 6 weeks, then I will leave them on until I get them on an established allopurinol dose. So until they hit the target or have an established dose, I would generally leave them on. Every time I titrate, I will leave them on, basically.
Fantastic. And Ayub, with the last question, perhaps. Ayub, you're muted.
Thank you, Priyanka, for an excellent talk. I just want to clarify prophylaxis, which we do for 3 to 6 months in severe kidney disease. I think Peter is suggesting we can use the regular dose, but the reference he sent says that severe kidney disease without dialysis, the numbers are double. And if you use that for 6 months, you will get into trouble. This was a single dose of 0.6 milligram. So for severe kidney disease, we need to adjust the dose. Dialysis, well, that's the reference.
I'm very happy being educated on this. I mean, I tend to go by 0.7.
Exactly, read one dose. Colchicine exposure was similar for subjects with renal function, mild impairment, or end-stage renal disease, but was up to 2-fold higher in subjects with moderate or severe renal impairment. So if you continue doing this for 3 or 6 months, there will be accumulation.
This is why we need clinical trials on patients with CKD3 and higher.
Exactly. And I don't think we are going to settle that question for now, but at least for a short period of time, let's accept that 0.6 milligram daily is acceptable. Can I ask one last question, hopefully? Is that the Febuxostat, I think I don't use it enough. I think we should embrace it. And if it has no renal issues, apart from the cost, what is the big deal, right? There is no risk of allopurinol hypersensitivity syndrome.
No.
And it is, if I'm not wrong, it is more potent than allopurinol in lowering uric acid. Right? How do you decide in the choice between the two?
So it is more potent in that it's only been compared to allopurinol between 100 to 300 milligrams. So we don't know what happens beyond that dose. But I think, yes, for up to 300 milligrams, if you look at the data of reduction in uric acid, it is faster with Febuxostat. And as I showed, there's no risk of greater chance or earlier flare with Febuxostat compared to allopurinol. So I think it is, a good drug to have as a second line, definitely. And I'm less concerned about its cardiovascular safety after the FAST trial.
Fantastic. That's really good to know. Thank you again for these wonderful rounds. I think we can keep talking about this issue. I know there are very strong opinions on many of these topics. Jan Davis is asking, is Febuxostat covered? I just looked up on ODB formulary. Is it covered or not?
No, we have to apply as EAP for that.
Okay. So that's the other big reason, I guess, why we cannot use it.
Yeah.
And allopurinol is like 8 cents versus Febuxostat is like, I think, $1.3 a pill or something like that. So that's the even if people are buying out of pocket, it's going to be a little bit expensive. Anyway, thanks again for this talk. I think we can chat offline about having a joint clinic as well eventually. Our division head, Dr. Karpinski, was on the conference, though she's left now. But thank you again, and look forward to working with you on many of these topics.
Thank you so much for having me. It's been lovely to getting to know you all, and yes, look forward to working with you very much. Thanks, everyone.